Hi, good afternoon, and thank you for joining PQA for today's Quality Forum Webinar. My name is Richard Schmitz. I am PQA's Senior Director of Communications, and it's my privilege to moderate today's discussion. Before we begin, I want to mention a few upcoming events. We have a Quality Forum Webinar on Tuesday, November 6th on the Medicare Star Ratings Update. And then if today's topic on charitable pharmacies is of interest to you, then you'll also be interested in the Social Determinants of Health Forum. That is November 14th and 15th in Alexandria, Virginia. And then immediately after that is the 2018 PQA Leadership Summit at the same site. Just a couple of quick logistical items. All attendee lines are muted. You're encouraged to submit questions throughout the presentation using the question feature in the control panel on your browser. And at the end of today's presentations, we'll select questions for our speakers to answer, and we'll cover as many as we can as time permits. This forum is being recorded, and a copy of the slides and audio recording will be made available through the PQA member portal within a week. And at the end of the webinar, we will have a brief survey for you to provide feedback to ensure that this series is meeting your needs and interest. So now I will introduce today's presenters for Charitable Pharmacies Improving Medication Access to Underserved Patients. Our presenters are Jennifer Seifert, who is the Executive Director of the Charitable Pharmacy of Central Ohio and also the Residency Program Director for the PGY1 Community-Based Pharmacy Residency Program at The Ohio State University. She has an extensive background as a community-based pharmacist and a deep interest in understanding and overcoming the barriers which people living in poverty must overcome to improve their health. Also presenting is Dr. Donney John. He is the Executive Director of NOVA ScriptsCentral. It's a nonprofit pharmacy that provides life-saving medications to uninsured patients in Northern Virginia. He is a practicing pharmacist, healthcare consultant, entrepreneur, and patient advocate. He also has considerable expertise in the areas of precision medicine, patient engagement, population health management, transition and care, and mobile health technology solutions. So at this point, I will turn the controls over to Dr. John, who will start our presentation.
Thank you, Richard, and thank you everyone for joining us today for today's webinar and taking some time to learn about charitable pharmacies. So our objectives for today are to discuss the various types of charitable pharmacies around the country and also discuss the role charitable pharmacies play in public health, highlight opportunities for collaboration with charitable pharmacies, and finally, where to start if considering a charitable pharmacy in your community. So what is a charitable pharmacy? A community charitable pharmacy is one that typically serves with expressed interest of improving health outcomes among the vulnerable in our community by reducing health disparities and increasing medication access. So typically, a community charitable pharmacy has the standard business features such as being a structured nonprofit or equivalent nonprofit status, having a valid pharmacy and pharmacist license, also following all local and federal regulations pertaining to the management of a licensed community charity pharmacy and or clinic. And finally, dispensing a therapeutically broad formulary of medications for free or at a significant reduced cost to the patient. So a community charitable pharmacy model, there are two different types. So I'll give you a little bit more detail. A charitable pharmacy program serves uninsured or underserved patients with low income. The charitable pharmacy program may be a pharmacy exclusive, where they only provide free care, or it may be incorporated to a pharmacy with a broader business plan. Typically, all charitable pharmacy models can be open door, meaning they serve eligible patients from their entire community or state. Due to limited resources, the models may be limited to geographical location. The two classifications for community charity pharmacy models are a charity-only model and a mixed model, where the charity-only is a pharmacy dispensing solely to patients under the charity program. And underneath the mixed model, the pharmacist dispenses to both insured and uninsured patients and engaging in other for-profit activities in addition to the charity program. So here I'd like to highlight the 5 different types of charity pharmacy models. The first is a charity only. A charity only could be a standalone pharmacy providing services for the uninsured patients, or a central fill pharmacy providing pharmacy services for a variety of free clinics. A second option could be a mail order charity only. And this is where comprehensive drug donation, redispensing, and disposal programs fall underneath. There's also a collaboration mixed model. And this is where charity pharmacy serves both insured and uninsured patients. In a clinic-based mixed model, that can be a pharmacy that's located on a hospital campus or inside a primary care clinic location. And finally, a hospital-based mixed model is a charity pharmacy and retail pharmacy located on a hospital campus itself. So a common question we get is, where do we get our meds from? So here I've highlighted the primary resources where most charitable pharmacies are able to obtain medication. AmeriCares and Direct Relief are 2 of the biggest vendors that charitable pharmacies and free clinics are able to access medications and medical supplies. Both AmeriCares and Direct Relief have direct relationships with pharmaceutical manufacturers and vendors where they are able to obtain supplies, which therefore are able to pass on to charitable pharmacies for free or to free clinics. Dispensary of Hope is another service that's where it's a membership model. As a charitable pharmacy, you have to pay to join Dispensary of Hope, but then you are able to get access to manufacturer donated medications that Dispensary of Hope has relationships with. The Minnesota Multi-State program is a group purchasing power group where you can buy directly. The charitable pharmacists pay to purchase drugs at discounted costs as part of this group purchasing offering. Also, traditional wholesalers like AmeriSource, Cardinal Health, and McKesson, the charitable pharmacies have contracts where they will purchase drugs at cost from these wholesalers directly. Drug repository programs started back in 1997 based on legislative action. And the primary purpose of drug repository programs are to provide an opportunity for where unused prescription drugs can be donated and redispensed to patients. The National Council for State Legislators highlighted 4 distinct programs recently. One was Iowa, where they created its program in 2007 and served over 71,000 patients and redistributed $17.7 million worth of free medication supplies. Wyoming, they started their program in 2005, and they've been able to fill over 150,000 prescriptions, which adding up to almost $12.5 million worth in medication value. Oklahoma created its program back in November of 2004, and they filled over 227,000 prescriptions valued at close to $22.5 million. And finally, Georgia, which is the latest state to have a drug repository program, but within the short period of time that they've been up and running, they've been tremendously successful in connecting patients to much needed resources of medications. So charitable pharmacy funding. Most charitable pharmacies have a variety of business plans based on their model. As I mentioned earlier, there is a charity-only model versus a mixed model. That helps to generate some revenue for the charitable pharmacy to operate. Typically, almost all charity pharmacies collect some type of dispensing fee. Some may call it a copay, some may call it a dispensing fee, some may call it an administrative fee. There's different namings for the costs associated. Charitable pharmacies are reliant on individual donors to help support the worthy cause that we have, but the primary funding comes from grants. And these grants are typically provided by foundations, corporations, health systems, and insurance companies. And because our funding is predominantly from grants, we do have to develop different services that are supported through these grant projects. Some of the main services that charitable pharmacies provide are medication access, medication therapy management, immunization, health education, care coordination, and research. So we'd like to say charitable pharmacies do have superpowers. We may not be able to leap over tall buildings or be faster than a train, but we're able to help our patients and in our community navigate through patient assistance programs, helping them to be compliant with getting the paperwork and following all the requirements that are set forth to get the medications they need. Also knowing how to get drug discounts, knowing what's available not only on a local, regional, and national level, but what other resources in the community are available where they can access not only medications, but health services. Typically, charitable pharmacies have relationships with all different schools of pharmacy and other universities where we serve as a training site for not only nursing students, pharmacy students, but also medical students and residents. And all this leads us to be very well connected in providing patient care. Because we are working with the most vulnerable population, we often have to get very creative and be very engaging to make sure our patient population is well cared for and has the best possible outcomes. So now I'd like to take some time to talk about Novus ScriptsCentral. This is the organization that I have the pleasure of running. So, go back. Novus ScriptsCentral, we were established in 2007, and we are a 501c3 nonprofit collaborative pharmacy. And our vision is simple: to improve the health of the community by empowering patients to take charge of their health and eliminating barriers to care. We partner with 13 free and travel clinics in 19 locations who serve the uninsured in Virginia. So we have a pretty broad geographic footprint in Northern Virginia. To date, we've touched almost 20,000 patients, providing over 560,000 months of prescription therapy, retailing at almost $73 million in value. The services, we believe in providing services to strengthen the health of the community. And we do this in 3 ways. First is our school-based immunization. Second is through medication access. And finally, third is our Educate Before You Medicate health education program. In terms of medication access, we provide a 30 to 90-day supply of medications to manage chronic illness for only $5. Typically, we have a formulary of 250 drugs only for medications dealing with chronic illness. We don't provide antibiotics or any acute need meds, and we don't provide any narcotics. Our Educate Before You Medicate health education program is a grassroots health education outreach effort in the community where we tackle health literacy head on. We provide interactive, culturally competent learning sessions within a variety of different settings. We could be at places of worship, libraries, community centers. We're often invited word of mouth to come in and really provide a group learning experience. We also are providing immunizations by working with the largest school system in our state and a local school of nursing program to immunize school-based children so they can start school. Children that are new to the country or new to our region often have to not only provide their full vaccination history, but also get a school physical done in order to start school on time. And we are able to help coordinate the immunization component of that process. Through our efforts, we're developing an Immunization Passport, which is meant to be used to help educate parents about the importance of immunization and the importance of following up to get the subsequent doses of whether it be MMR or Tdap and other vaccinations. Finally, the other service we provide is research. Several years ago, we worked with Northwestern, Emory University, and Harvard University to do a medication label redesign study, where we were able to redesign our pharmacy labels to evaluate, is there an improvement in patient outcomes based on expressing information in a very unique fashion. And based on that study, there has been work done in this space where corporations have provided redesigned pharmacy labels to be used out in the community setting. But it all started within our small region of Northern Virginia, working within our 13 clinic network. We also participate in evidence-based research projects, such as the Kaiser Permanente's All-Faith program. And what this program is a preventative protocol of core medications prescribed to diabetics to prevent cardiovascular complications. We follow these patients from the beginning onwards to make sure that they're compliant with their medications, but also that their health outcomes, we monitor their LDL, their lipid panels, their blood pressure, and other important vitals and make adjustments as necessary. Based on our pharmacy label redesign, we started to work with Meducation software, which is provided now through First Data Bank, where our pharmacy labels come in 22 different languages. We are really focused on making sure our patients understand what they're getting and how to take those medications effectively. So an example of our Educate Before You Medicate outreach here for you is our work with Arcadia Farms, which is a mobile market, farmers market, where we've created a handout here that you see on your right that talks about food and drug interactions. Typically, when people are encouraged to go to a farmer's market, they are trying to be health conscious, try to find fresh fruits and vegetables to get them to be healthy. But oftentimes people don't realize, based on your medical condition and your medication, that certain vegetables may not be the most appropriate. So we spend time educating the attendees at the farmer's market about certain vegetables that they need to avoid and other food and drug interactions. And we spend time working with kids on teaching them how to get superpowers based on the fruits and vegetables that are being sold at the farmer's market. So that would just create an interactive family learning experience where the parents are not only educated about what they need to be careful and mindful of, but the kids got involved in learning how to, what the benefit of eating certain fruits and vegetables were as well. So recently, Novus ScriptsCentral, we launched the Novus Scripts Complex. This is a free tool on our website that's meant to help connect community members to resources. So it could be used by anyone in the country where they just type in their zip code into the search box. And once you put in your zip code, you're able to find resources relating to food, housing, goods, transit, health, care, education, and so on. These, when you click on any one of these resources, you have the option to filter based on specific criteria. So client-specific criteria. It can be based on language preference, income eligibility, fee structure, hours of operation, pretty much like Yelp, where you can narrow down your search criteria, search field. You're able to do that through the software. The company we work with, they make sure that every single link is updated every 6 months, where they call every phone number and check every email to make sure that it works. There's never a database that's 100% comprehensive. So I can say, for the most part, there is, within 90% reasons, there are a majority of the resources that at least gives you a fresh start to help connect people. And this is part of our mission at Novus Scripts. As we're trying to eliminate barriers to care and connecting people to resources, we want to make it easier for them to find these resources. So Virginia is the most recent state to pass Medicaid expansion. So starting in 2019, over 400,000 Virginians will have access to Medicaid. There are 6 MCOs in our state that will be providing Medicaid coverage. But what happens typically for a patient that's been in a safety net environment going to become now insured, they're not going to be very savvy in understanding the complexities of a formulary, about prior authorizations or step edits. And what we're looking to do is to work to help the clinic providers throughout our state by answering questions for them. So how to transition a patient from a drug that they may have gone through once before through a PAP application, now to, okay, this is not covered on Medicaid. What do I switch the patient to? Sometimes there's confusion where they look at it as an apple-to-apple comparison of I switch drug A to drug B and it's the same to treat the illness. But we all know that's not the case. You need to look at more criteria in terms of what's the medication indicated for, what's the dose that's appropriate based on the patient needs, and making sure they're effectively put on the right medication. So we're hoping to collect the data to look at the patient-specific information and empower the providers at these clinics to make sure there's less disruption in care. Make sure patients are appropriately prescribed the equivalent medications that's on Medicaid formulary, so now they're able to afford it. So they're not only accessing medications, but they're affording the medications. And then we can also help these clinicians navigate the complexities of doing a prior authorization or understanding concepts such as step edit. Not too far. So we are one of the few nonprofit pharmacies in the country where we have our own EMR system. And the goal of our EMR system is to not only utilize the medical data from the 13 different clinics that we're connected with, but link that up to the pharmacy data that we're collecting to do create comprehensive medication profiles and population health services. The future goal within our EMR system is to provide telemedicine services, where we can virtually connect with patients and providers to offer health education. As a nonprofit, we not only believe in helping those in need, but we also believe in giving back. And one of the ways that our staff and our team do that is by putting together care packages for our troops. We work with local businesses, and in this picture you see we work with Kensington, which is a local senior living community, where we collaboratively came together to write words of encouragement for the troops stationed overseas and put together care packages that were distributed not only to troops stationed overseas, but also to homeless veterans that live here in Northern Virginia. So with that, I'll pass it over to my colleague, Jennifer.
Thanks, Donney. Hi, this is Jenny Seifert. I am a pharmacist and the Executive Director of the Charitable Pharmacy of Central Ohio. It is a pleasure to speak with you today and to describe the Charitable Pharmacy as a model and to provide a few pearls if you're considering a charitable pharmacy in your own community. We opened in February of 2010 with the mission to provide affordable and appropriate pharmacy services and to coordinate access to healthcare for people who are vulnerable in our community. You see there a picture of the building where we're located. We are a public, private, and faith-based initiative to fulfill our mission. You'll see in the background of that picture some skyscrapers, some modest sized ones. We are in Columbus, Ohio, and we are in downtown Columbus, Ohio. We are on 2 major bus routes and have a large parking lot, which makes it accessible for our patients to reach us. To define the scope of need of our charitable pharmacy, I'll show you just a graphic of the 88 counties in Ohio and point out Franklin County, which is, of course, the capital of our state with a star. So the yellow shows that up to 20% of our Franklin County residents live in poverty. And to expand on that, on the next slide, if you expand to 200% of the federal poverty level, which is the qualification for being a patient at the Charitable Pharmacy of Central Ohio. An Ohio Medicaid survey in 2015 showed that over 34% of our Franklin County residents were under 200% of the federal poverty level, which is over 400,000 people. And when asked if in the last year they had gone without necessary prescription medication, 24% of those patients, or 80,000 people, answered yes, they had gone with that unmet need. When we start to feel good about what we are doing in a bustling, busy charitable pharmacy, we recognize that we are a drop in the bucket. So the scope of need in our county is at least 80,000 people. And in 2017, we qualified 1,600 unduplicated patients for services at our charitable pharmacy. Since we've opened, we've qualified over 6,700 unduplicated patients. We have conducted over 60,000 one-on-one pharmacy consultations, and I'll describe those in more detail in a moment. We've filled over 400,000 prescriptions, which is an AWP of over $35 million. And we tell our sponsors that we will turn every $1 that they donate into $8 in medication. The last 2 points here are that we've demonstrated a reduction in hospitalizations by 1 per patient per year, and we've shown a stabilization in healthcare security for our patients. We do have 3 publications in national peer-reviewed journals. If you search my name, Jennifer Seifert, you'll find those publications. I'm not the primary author on all of them. Our resident pharmacists are, but I'm a common denominator. So for more in the literature about us, you'll find our published studies under my name. And this is a screenshot from our website, which will contain some useful information. If you'd like some more information after this webinar, it's charitablepharmacy.org. We qualify patients for 1 year, and then we check in with them at 6 months to make sure their address hasn't changed, their income has not appreciably changed. We check on their insurance, etc. We make an appointment for the first time a patient comes in, and then after they're qualified, from there on out, it's first come, first served each day that we're open. Our qualifications, again, at 200% or less of the federal poverty level means for 2 people, that's less than $33,000 per year. And we are open to the public on Monday, Tuesday, Thursday, and Friday. We're closed to the public on Wednesday because we're doing a lot of inventory work. We are restocking our shelves. We're taking a look at what we've gotten donated. We're organizing for the rest of the week. And we, on a typical day, will see about 60 patients and sit down one-on-one with them. And we'll fill at least 350 prescriptions. What we found over the years is that our patients are very medically unstable, meaning we fill in 30-day quantities, but our typical patient, their medications change frequently, so that 15 to 20% of our patients come back more than once a month to receive either a further assessment from a pharmacist or a change in medications. Our clinical services are fairly extensive at our location in Columbus, Ohio. We provide medication at no charge to the patient. We provide vaccinations. Thus far, I think we have vaccinated around 200 of our patients in this flu season for influenza. Medication management is an important part of our medication use process, and it includes that one-on-one consultation with each visit. It is our model that we are passionate about, is that a patient receives on average about 20 minutes with a pharmacist or a pharmacist resident or an APPE intern at each visit. This is a representative of our team. So we have 3 pharmacists, myself and 2 part-time pharmacists. We are all geriatric board certified. We recognized a couple of years ago as our patient average age was approaching 60. And as you would recognize that patients that live in generational poverty, that physiologic age is older than 60, that as we're working with them clinically, we saw the need to look towards that advanced certification to elevate the care that we give them and that we are able to teach our students. We have 2 PGY1 community-based residents at the Charitable Pharmacy. Through the Ohio State University Residency Program. We have 3 pharmacy technicians, a business manager, a patient services coordinator, a waiting room attendant, which is arguably the most important position in our team. Our development director was a fantastic addition 2 years ago to our team and helping us cultivate our relationships. And we have over 300 volunteers donating more than 3,500 hours annually. I bolded that last bullet because I want to highlight for a moment our advanced pharmacy interns. So each year we have 55 of them, and they spend 1 to 2 months with us. And in those months, they will see at least 150 patients per intern in our medication use system for that one-on-one patient consultation. So our experiential education program is essential for us, and we really emphasize the pharmacist patient care process, which allows us to partner with several colleges of pharmacy in Ohio. The Ohio State University is only a couple of miles away, so we partner extensively with them. And we have hosted over 330 rotations since we started. That pharmacist patient care process, where students learn to collect information, assess the patient, create a plan, implement that plan, and then follow up on the plan, is integral to our process and our outcomes. Again, our patient population is approaching 60, and our average patient takes 8 medications. And not surprisingly, those common ambulatory care diseases reach high proportion in our patients. So most of our patients have hypertension. We're approaching half have diabetes. And therefore, with that complexity, medication management becomes important for our model. For our medication use system, we currently use QS1 for our prescription processing software. And secondarily, as Donney mentioned, the EHR, we 2 years ago converted from paper charts where we were keeping track of people's blood pressure and blood glucose and doing our soap notes to an electronic health record. So we use one called Practice Fusion, and at each visit, we keep a soap note. It allows us longitudinally to look each month at a patient's blood pressure or blood glucose. We're a CLIA-waived lab, by the way, in order to do that blood glucose. And it allows us then to coordinate back to the patient's prescribers based on what we're seeing for patients' medication efficacy. It allows us that longitudinal care, and then it really enhances the precepting of students, so and resident pharmacists, as we are able to look at the quality of their soap notes and their care to make sure we're assessing competencies and increasing competencies. So we identified a work to resolve drug-related problems. In 2017, the first full year of implementation of our EHR, we identified nearly 700 drug-related problems and worked to resolve them. And last year, our resident had a project, her major research project was on cost avoidance. And she looked at 2 weeks worth of our drug-related problem resolution, working with Outcomes MTM and their actuarial investment model, putting a value on the resolution of these problems. And that value was $70,000, which the manuscript is in process. And of course, I will use that information as I go back to our sponsors to describe the effectiveness of a pharmacist involved in this type of practice. We have 11 sources of inventory at our charitable pharmacy, and Donney had mentioned and gone over several of them. I'll point out that there are different patient requirements for each of those inventory sources. So for instance, some go by net income, some by gross income. Some are only for patients under the age of 65, with the thought that those over 65, Medicare Part D, should be able to provide for their medication needs. I am a very passionate advocate that is not the case in our patients in many instances when you're taking 10, 12, 15 medications. But we have patient services coordinators that qualify our patients and that put them in the right bucket so that we can pull the right inventory source for them. We also use a pretty robust repository system here in Ohio. So our long-term care facility pharmacy contribution is pretty significant for us. And then in addition to our donated inventory, we purchase medications. We have a budget to purchase medications. We help uninsured and underinsured patients. So as Donney mentioned, a model could be only uninsured patients. In Central Ohio, Ohio was quick to expand Medicaid. And that really changed our landscape, as from 2010 to 2015, more of our patients had access to primary care, which was fantastic. But there comes with that a navigation on the part of the patient, which becomes so challenging for our patients. So we, as a pharmacy and a board of directors, decided that we would serve underinsured patients as well. I tell our students, I remind them, the definition of underinsured patient is that if you're under 200% of the federal poverty level and you pay more than 5% of your income on healthcare costs, then you're underinsured. So our typical patient that may live on $900 a month, if they're spending more than $45 per month, they're underinsured. And if you're taking 8 to 10 medications, you can certainly see how that can happen. So we'll bill a patient's insurance if the patient has it. We look it up for them. We will check our sources to see if they have insurance when they're qualifying. We'll assess a patient's ability to pay. work through formulary issues. We do have the ability to help them apply for extra help for Medicare patients, which brings their copays down substantially and eliminates their premiums. And we won't turn anyone away for lack of ability to pay. So again, we have learned that navigation has become a very important part of what we do in helping patients. Our strategic plan is 2017, 18, and 19, and it focuses on 3 areas. I think it's important to have a strategic plan, so if you're starting to think about a community-based charitable pharmacy, having a facilitator that helps to develop your strategic plan covering 3 to 5 years, I found as a new executive director 3 years ago it was very beneficial for me. So our 3 areas are innovative pharmacy practice, revenue diversification, and defining a hub and spoke model. So under innovative pharmacy practice, we wanted to demonstrate and really bring home the pharmacist's impact on hospitalization. So having that publication really helped. We wanted to convert to an electronic health record, really look at health information technology. We have collaborative practice agreements formed, but I will say, looking at our data over the last quarter, we received prescriptions from 1,300 prescribers. So we are working on focusing our efforts on the appropriate prescribers for collaborative practice agreements. Next year's budget, I have 15% is earned income, which is up over the last couple of years, in increasing our individual donor base. And we know that in our urban setting, we have neighborhoods that we may not be reaching effectively in our county. So we are, as a board of directors, looking for the best model for expansion to meet those needs, keeping in mind that our passion is that one-on-one personal consultation. I often get asked how we do exist. So this information is available on our website and linked to our annual report as well. These are some of our major donors. We also have an incredible individual donor base, and there are some organizations in Central Ohio that are not identified here by logo. And next, Donney is going to talk about a more general some information on how to start a charitable pharmacy. But before he does that, sorry, I have just a couple of points. So I get called every 2 to 4 weeks or so from someone saying, how do I start a charitable pharmacy? So we will have a video on our website. We are focusing on having it by the end of the year. I would recommend a needs assessment. So that data at the beginning where we identified 80,000 people in our county, according to an Ohio Medicaid survey that showed people going without needed medication, that was impactful for us. So doing a comprehensive needs assessment, choosing a model, the depth of your clinical services. We are in an urban area that's concentrated where our patients can get to us, and we are close to a college of pharmacy. And we're at a college of pharmacy that has community-based PGY1 residents. All of those things come together to make that one-on-one patient consultation that is our focus doable. Choosing your referral system, I think it's fascinating. Those systems, like the one in Virginia, working with different free clinics over multi-county areas. We are an open referral in a pretty concentrated area. If your area has 340B drug discount contracted pharmacies, understanding how you might fit in there, whether you would be one or whether you would augment the services provided by them is an important consideration, and whether you would serve just uninsured or both uninsured and underinsured patients. What type of practice component you will have. So again, our IPI and APPIs are a consideration. We accept APPIs. We do not have intermediate or introductory students with us. Ohio has a ratio of learner to preceptor of 2 to 1. So that means if we have 5 interns practicing pharmacy, we need to have 3 pharmacists on duty at the same time. And as you are considering the factors around a charitable pharmacy, having a team of passionate preceptors that is willing to teach, orient each month, really work on clinical competencies, I think is integral. Another integral part of a charitable pharmacy is the formation of that board of directors. We have representatives from all 4 major health systems in Central Ohio. We have representatives from several large businesses and a nice mix of skills and talents and passions. So I couldn't say more. I couldn't overemphasize the importance of the board of directors as it's chosen for a charitable pharmacy, and identifying those in the community that are community leaders, that are political leaders, that may join in the mission of the pharmacy. And now I'll turn it over to Donney, who's going to talk about a little more global look or tool for starting a charitable pharmacy.
Thanks, Jen. Excuse us while we get the slide load up. So, National Association of Free and Charitable Clinics recently stated that there are over 1,400 free clinics throughout the country. So we have a good idea of the number of free clinics in the country, but we really don't know how many charitable pharmacies are around the country. So a group of charitable pharmacies came together to create a playbook. First, they wanted to figure out how do we learn about each other? How can we share our best practice to help support individuals and groups that want to start charitable pharmacies within their own region? So if you go to the charitypharmacy.org website, which is different than Jennifer's website, which is charitablepharmacy.org, this is charitypharmacy.org, you'll find that there's a link at the very top to a playbook. And this playbook is a how-to guide on starting a charitable pharmacy. It goes through all the detailed information that Jennifer mentioned and then some. It talks about the different types of models, the structure that's needed, how to set up contracts with vendors, the legal requirements that you need to think about, but it gives you a great starting point for those that are interested in starting their own charitable pharmacy within their region. The Charitable Pharmacy Playbook is free for anyone to access, so I encourage you to please share that resource with anybody that's looking at starting a charitable pharmacy or that wants to learn about different models that are out there. The Charity Pharmacy organization is still fairly new, and we are trying to identify other groups like us that are working in this space so we can all be connected and really figure out how can we be innovative together to improve patient care. So we highlighted a lot of what charitable pharmacies are, but there are distinct challenges that we all face. And I've highlighted 3 main challenges that we are facing currently as a whole collective group. One is medication access. There is a struggle sometimes to access affordable medications that we have to purchase. As Jen alluded to, she has a budget to purchase some drugs. I have a budget to purchase some medications. Direct Relief and AmeriCares will donate supplies, but we all have contracts with wholesalers, whether it's AmeriSource, McKesson, or Cardinal, that we need to purchase these medications. And with the rise in drug prices, especially with generics, we have to often pick and choose what medications we keep on a formulary. And that also impacts what medications are available to be donated for Direct Relief and AmeriCares, because it depends on what they're getting sent back from the pharmaceutical manufacturers. There's also the issue with patient assistance programs. There are less branded agents to treat most of the chronic illnesses that are available through a PAP program. There are a lot more newer agents that may be available, but they're not always the most appropriate. And one thing that we try to help patients is to make sure that they're sustained on medications that they can access and afford ongoing. The other restriction with PAPs is sometimes they won't allow third-party groups such as us to really engage on behalf of that patient. They want more of a direct physician to PAP program relationship where the physician has to send in the paperwork and navigate the system, so then therefore the medication gets shipped directly to the patient. And that's not an easy process. There are so many different things that come into play. And at Novus Scripts, we do get audited by the pharmaceutical manufacturers and our partners, AmeriCares and Direct Relief, where they make sure that we are checking eligibility and verifying that the medications we're receiving are going to the people that are truly in need. There's also a lack of specialty medication access. Specialty medications are becoming more of a prominent player within the space of patient care, especially with biosimilars and other drugs that are really targeting treatment therapy, there is a cost associated with that. And those medications aren't always affordable or accessible to us where we can then dispense to patients. The next issue that we are all facing is funding. Sustainability is a thing that I believe Jen could agree that as an executive director, I wake up thinking about funding, I go to sleep thinking about funding, and I start again the next day. And one of it is there is not a lot of support for pharmacy services via grants. Oftentimes we always hear the line, sorry, we don't fund non-direct patient care services, where they don't view the pharmacy component of patient care as a truly vital part of it. What most funders would like to see is we fund a physician visit or a nurse visit because that's providing direct patient care. And the argument we come back with, what good is it for a patient to be diagnosed with an illness, but not to have the treatment to manage that illness? And then we get back to the same line, we do not fund direct patient care services. So that's part of the education process as Charitable Pharmacies, that we are constantly talking with funders and donors to educate them about the important value that we bring to the patient care setting. Also, most of us, from a grant perspective, we're based on volume, the volume of services, meaning the volume of prescriptions dispensed. You know, the typical landscape with ACA reform, we went from the volume-based care model to a value-based care model. And Charitable Pharmacies, we are trying to move to have that dialogue more of the value that we bring in, not just the volume of more drugs dispensed. We want to show, as the research that Jennifer's residents have highlighted, the realistic savings that we can bring by having these interventions of getting patients off of unwanted medications is extremely important. Finally, lack of resources. As we try to get creative in our solutions and developing programs, we try to engage with different vendors at different times. But because we're working with underserved patient populations, there's a misnomer that we are not as big of a fish, so there's not a big enough of a contract to pursue with us, that they don't get engaged. So oftentimes we're chasing after different groups and different vendors to ask to collaborate, but we don't hear back because we're not viewed as a high priority, even though we are working with the most vulnerable patient demographic in the country. So collaborating with the Charitable Pharmacies. As I mentioned earlier, Charitable Pharmacies are always looking at ways to collaborate with all healthcare industry sector partners. We are eagerly focused on creating partnerships with different stakeholders so we can improve patient care for our community. Some ways that Charitable Pharmacies can help is that we can serve as a pilot site to test new solutions, whether that's mobile health apps, health IT software, whether it's EMR or analytics software, patient education materials. If you've developed educational content that you want to test in a different demographic. As I mentioned, Novus Scripts, our labels come in 22 different languages. Northern Virginia, we are a very culturally diverse patient demographic. So we have this whole access to these very unique demographics that we can engage with and test out education material to see, does it resonate? Is the key message being connected or conveyed? That leads me to serving as subject matter experts in patient engagement. Because we are working with the most hard to reach patients, we have to become stewards of knowing how to communicate effectively in a culturally competent manner. So oftentimes, many of us will be working with using motivational interviewing techniques. You know, that's part of our workforce development thing that we all do, is we really make sure that we know how, that our volunteers and staff know how to engage patients and how to ask questions so that patients feel supported. Also, the opportunity to participate in clinical research. There's a lot of research that can be done through our demographic. We, as Jen alluded to and I alluded to, we both have EMRs. Not everybody has an EMR, but they have some way of either Excel spreadsheet or other data tracking methods. The other thing we all do is promote clinical services and community service offerings. We often highlight what's going on within our community. Just as I mentioned, one of our superpowers is knowing where to look for drug discounts. It's also to know what's going on within our community. So for example, Novus Scripts, we're working with a local regional grocery chain to highlight immunizations for those parents that are coming to get their kids vaccinated at the school. So we've connected with a regional supermarket pharmacy, so they now could serve a need for parents that had no way of getting vaccination before. Secondly, there are screening programs. So for example, Sam's Club provides monthly screenings for those in the community. And as we do our education outreach, we'll highlight to the community residents that there is a screening happening at Sam's Club or at Walgreens or CVS is doing a flu clinic. We try to cross-promote because at the end of the day, our focus is making sure that patients are connected to the resources so they can improve their health. There's also a vision program. You know, for back to school, we did a lot of educational outreach to educate parents about safe best practice for mental health wellness for their children. But we also highlighted that there was a vision discount program available through Walmart to get their prescription glasses for their children at a low cost. So we often are always searching for deals, looking at how can we really bring resources to our community partners. And finally, workforce development. We are a true epicenter of training the future generation of leaders because of the dynamics and the diversity of knowledge that we are able to facilitate as preceptors and as educators. So if you have any questions at this time, please submit them via the questions panel. And I'll pass it over to Rich.
All right. Well, thank you, Donney, and thank you, Jennifer. You've both laid out in great and helpful detail the fundamentals of operating or working with a charitable pharmacy. So we have some time to take questions. And the first question, Donney, I'll let you take this first, but Jennifer, you may be able to weigh in as well. Do you have percentages on how many charitable pharmacies are in each of the categories of models that you described near the beginning of your presentation?
So we don't have a comprehensive list yet, and that's one of our goals for charitypharmacy.org, is we are trying to collect that data. We try to identify the different charitable pharmacies underneath each of those buckets, so that way we strengthen collaboration going forward. But it is one of our goals for charitypharmacy.org to get that information.
Jennifer, based on your experience, Jennifer, do you have a sense of what the most common charitable type is based on your experience?
That's a great question. And to Donnie's point, no, I think that we start organically due to a need that's identified in these communities. So we don't currently have a solid network and way to identify ourselves. So no, unfortunately, I don't have any more information to add. I know that, like I said, I get calls and emails fairly frequently wanting to know how we started and how to start one. So.
Our next question, and perhaps Jennifer, you can take the lead on this one. How can a charitable pharmacy differentiate itself from 340B pharmacies, especially 340B co-located pharmacies?
Yeah, that's a great question, and one in Central Ohio that's been very interesting because we have a pretty wide network of FQHCs here in Central Ohio. And what we find is there's just an abundance of patients that are going without their prescription medications. Last year, we identified that 85% of our patients come from non-covered entities and 15% were coming in from covered entities. So I'm currently, this week and next week even, working with the FQHCs to see what the needs are for their FQHC patients that are not being covered with their contract pharmacies and why they're coming to us. So it is an ongoing issue. Right now, we are not a contract pharmacy, and we are really catching more as a safety net for patients that are coming out of our major health systems and some private primary care offices. So I think that there's room for charitable pharmacies to be contract pharmacies, and we may move there in the next few years depending on the needs identified on both sides. But right now, we work more with patients outside of FQHCs.
Donney, I'll direct this question towards you. You know, could you kind of talk a little bit about what about the system and the barriers you face, you know, that you know make it so difficult to help people in these situations who need to rely on a charitable pharmacy for access to medication?
I think part of it is just navigating the system where they've sought out help and then they feel they're distressed, where they've been given a diagnosis, they've gone for a breast cancer screening or some type of screening, and then they look at the cost to treat that illness as unattainable. So oftentimes they don't know where to turn, and that's really a lot of why we're doing our educational program and outreach, where we explain to people if you have insurance, how to use your insurance effectively, whether it's medical or prescription, and if you have no insurance, where can you go to get help? Where do you go to get screened for different things? But it just, up until ACA rolled out, pre-existing conditions would disqualify you from getting healthcare coverage. So there's the stigma that my illness is not covered or the cost to treat my illness is going to be so outrageous that I'm just going to live in silence and suffer in silence. So part of our challenge is really making sure that communities that are in need are made aware, but also that the resources that we refer people to can handle the volume. Because the last thing we want is to refer somebody to a resource and say, I'm sorry, we can't help you. Because it takes a lot of effort to build that trust, and it's very easy to lose it if we're not true to our word of here's who can help, and they can actually do so.
The next question I'll pose for both of you, and Donney, I'll let you take this first. Do health systems for your pharmacies in your communities refer patients to you for care coordination and transition of care programs?
Yes. So we work with one of our local health systems to deal with the transitioning care patients. So patients that are going to be recently discharged from the hospital that are uninsured, we will help to coordinate their medications until they're being able to be referred into one of our safety net networks within our region. So during that time period, we are helping to coordinate the discharge meds and making sure they have access to it, helping to start the PAP application to see if they become eligible for patient assistance offerings. But there is the collaboration with the local health systems to minimize the readmission. And I'll let Jennifer speak to the great research that she has showing the quality of her work.
Yes, and the answer would be yes, that we also are involved in transitions of care and view it as a very important service that we can provide. We go about it by making sure we educate the groups of social workers and groups at our house systems, and there's 4 major ones in Central Ohio, about how to get a patient to us. And then secondarily, we have this year started to embed our community-based PGY1 residents into some of the practices for longitudinal learning experiences with our health systems. So that's been a win-win for the resident and for us for coordinating the information and the care that we can provide.
That's great. So we have time for one last question, and Jennifer, I'll let you take this first, and then Donney can weigh in. How can individuals or companies go about finding local charitable pharmacies to volunteer at or support in some way?
Yeah, so I think asking pharmacists in the area. So we have a network that has developed organically of our community pharmacists at retail pharmacies, community-based pharmacies that know about us. So if there are organizations that are looking to find us that don't find us quickly on a search, I think we're fairly easy to find on a search, and we do get those requests from community groups that want to come in and volunteer or contribute or offer a potential grant for us. So I think it's connecting through a search, hopefully someday through the charity pharmacy organization, and then just reaching out to pharmacists who we're just innately want to be aware of the resources for our patients. So I know in Central Ohio, if they were to ask our local pharmacy, their local pharmacists, many of them would be able to point them to where that charity organization is that works with patients that go without medications, if that's a passion or an interest that's seen for a group.
And as Jennifer pointed out, the one goal is with charitypharmacies.org is to kind of have a national database of charitable pharmacies that you can type in your zip code and you can see one pop up in your local area. The other way that corporations and entities can look to identify charitable pharmacies is speaking with their state association. Almost every state has a free and charitable clinic state association where most charitable pharmacies will work with the state association in some capacity for programmatic support and just collaboration. And so I would encourage everybody to check within their own states, within the Free and Charitable State Organization, about what information that they have. And if they don't have it, they are the most well-equipped at finding that information for you as quickly as possible, because they're very well connected within all their members and their network to identify what local charitable pharmacy is providing what service. And if you use the Novus Scripts Compass on our website, just to give a plug, you can type in your zip code and you can find pharmacy services, and you can filter based on free or reduced pricing and so forth.
Well, great. Well, we are at the top of the hour. I'd like to thank Donney John and Jennifer Seifert again for today's informative presentations, and thank you to everyone in our audience for your participation and questions. Please take a couple of minutes to take the survey that will pop up at the end of this webinar. Your feedback will help us. And again, a final plug for upcoming events. We've got a Quality Forum webinar in less than 2 weeks, and then 2 events in Alexandria, Virginia, the Social Determinants of Health Forum, and then the PQA Leadership Summit. So thank you again all for attending today. We look forward to having you join us for future webinars and events. Goodbye.